The following program is a Town of Colonie television production of the William K. Sanford Town Library.
Hello everyone, and welcome to Health and Wellness. My name is Paul Drezelo, and I'll be your host. Today we're going to be talking about sleep medicine and issues related to that. Topics such as sleep-related disorders, diagnosing them, treating them, as well as some general lifestyle-related issues related to sleep. So to help us talk about some of these topics, we are very fortunate today to have with us Dr. Luke Pluto, who is a sleep physician with Albany Medical Center. So welcome, Dr. Pluto. It's really great to have you here today. So what I was thinking is we could probably start out with some general areas about sleep and some of how you go about treating and diagnosing, and then talk about particular conditions after that. So,
that's fine.
Okay. So generally, we are going to be talking about particular conditions, but generally speaking, what type of disorders you really see in your field at a general level?
Okay, so I'm at Albany Medical Center, and I practice out of their sleep center or sleep clinic, which is at 1365 Washington Avenue. And so we have a very capable group of people. They're too numerous to thank individuals, but I work with Erica and Renee and Matt, and so they really do help the organization run smoothly. So we recently became accredited by the American Academy of Sleep Medicine, and so this is a recognition that not only do we diagnose and treat sleep apnea, which is a very common sleep disorder, but we do treat the full range of sleep disorders. And so these would, in general, include problems with excessive sleepiness and difficulty sleeping, which are certainly related, because if someone doesn't sleep well, they're not going to be able to function effectively the next day.
Right, right. How do you go about determining whether someone has a sleep disorder, just in general? How do you go about determining whether someone has a particular disorder, or, they're just temporarily having sleep problems? What is kind of the basic difference between?
So, like any problem in medicine, it's important to listen initially and really hear the problem from the patient's point of view. I'm particularly interested in knowing why someone who may have had a sleep disorder for years decided to come at that particular instance. If there was a problem that arose, or if someone pointed out to them, or if it was a physician that said, I suspect that you have a sleep disorder, I'd like you to see a sleep specialist.
Okay. Regardless of the particular condition, do any of these disorders have long-term impacts on people's health, and in general terms, do they have that type of capability?
Yes, certainly. There would be the subjective feeling of sleepiness or difficulty sleeping, which would impact ability to function effectively. But moreover, particularly in the instance of sleep apnea, there has been a strong correlation between sleep apnea and cardiovascular problems. And so this has been studied in very large studies over the years. There's a very close correlation between obstructive sleep apnea and hypertension and problems associated with that, such as heart attacks and strokes. There's also a relation between sleep apnea and atrial fibrillation, which is a heart rhythm abnormality. And so the sleep apnea can affect daytime functioning, but also have a direct impact on medical conditions, particularly those related to cardiovascular problems.
Just out of curiosity, how does sleep impact? Is it known anyway? What's the impact that sleep problems have on cardiovascular disease? Is there any particular thing, or is it just a correlation that's been noted?
So in sleep apnea, there's a disorder in which a person falls asleep and the brain does not give enough signals to the muscles that keep the throat open. And so when the individual falls asleep and takes a breath, the upper airway collapses, and so there would be repeated episodes of no air movement throughout the night. And so any episode that lasts more than 10 seconds would qualify as a respiratory event. During this time, there's no airflow, the oxygen is going down, and then the person will wake up with sometimes a very loud snoring type sound. During this time, the body releases adrenaline, and it's thought that it is these repeated episodes of adrenaline release at the inappropriate time that leads to cardiovascular problems such as sustained elevation in blood pressure, such as propensity to heart attacks.
Okay, all right, that's definitely very interesting. Is there any like lifestyle type factors that play into any of these at all? Is there anything, diet, exercise, or whatever? Is there any of those type?
Oh, certainly. So it is important to tailor the device to the particular problem, but weight plays an important factor in sleep apnea. Although not everyone with sleep apnea is overweight, as someone gains weight, the sleep apnea becomes more severe. So it's common to hear people say, well, I've snored a little bit for years, but for a particular reason, and last year I've gained perhaps 50 pounds, and now I not only snore, but now people say that I don't breathe at night, and I find that I wake up and I feel like I haven't slept at all. Other lifestyle interventions would be exercise, if possible, and also substances play a very important role in this. So if someone is having difficulty sleeping, it's important to ask about their caffeine consumption. It's also important to ask about smoking, which in particular can interfere with sleep apnea. The smoking itself can aggravate it, but also the nicotine can interfere with a patient's ability to sleep or to stay asleep. Alcohol and sedative medications and opioids can all worsen sleep apnea. So yes, a healthy lifestyle is very important.
Does you mentioned exercise, and exercise I'm assuming is beneficial for sleep, but what happens if someone comes home from work and they exercise at night versus the morning? Can that interfere in any way, or is it just generally?
Yes, that's interesting, because at one time it was felt that it was most important to exercise in the early evening, and that the exercise should not be too vigorous. But as it turns out, any exercise on a regular basis is beneficial. That's probably more important to get some exercise, whatever works best for the individual. The only exception would be, it's felt that very vigorous exercise just at bedtime, particularly something like very heavy weightlifting just prior to bedtime, may interfere with sleep onset. But other than that, regular aerobic exercise is important for good sleep and important for mental and physical well-being in general.
Right. Exactly. We're just generally speaking, what about something like snoring, which a lot of is that considered a sleep problem, or is that what actually causes it? And is it really is it indicative of something else? Or?
So snoring is caused by vibration of the palate, and also it's caused by nasal obstruction. And so snoring is a symptom, but snoring by itself does not indicate a sleep disorder. It would be very loud snoring, or snoring associated with episodes of not breathing, or very loud snoring associated with changes in the body build, such as increased weight, increased neck circumference, and also the association with any medical problems such as high blood pressure or diabetes or heart disease.
Okay. You had mentioned sleep apnea before, and let's start talking about some particular conditions that maybe some people know and some people don't know. But sleep apnea you had just mentioned a few minutes ago. So, and you kind of talked about what it was. What are some of the other risk factors that people have for that particular condition that would impact their likelihood of getting it?
So in addition to increased weight, low thyroid hormone can be associated with sleep apnea. So if I see someone with sleep apnea, I will check to see if they've had their thyroid hormone checked or if there's any symptoms such as sluggishness or swelling at the ankles, which would indicate the association with hypothyroidism. And the other problems that we mentioned, such as increased weight and accompanied by increased blood pressure. I would say the most common constellation of problems I see is obstructive sleep apnea associated with high blood pressure and associated with increased weight.
Okay. Once you've made that type of a diagnosis on someone, and actually, how do you go about identifying sleep apnea? Actually, while I just mentioned.
Okay, so in the proper setting of snoring associated with episodes of possibly not breathing, which would indicate a very high possibility of sleep apnea, it's important to do a test to quantitate to find out just how severe this is and how often the episodes occur. And so the test that has been the gold standard for decades is called a nocturnal polysomnogram. So the nocturnal would mean a nighttime test, and a polysonogram is a collection of various variables related to sleep and breathing at night, all recorded in graphic form. So this would include brainwave activity, which is known as electroencephalogram, monitors about the nose and the mouth to detect airflow, monitors around the rib cage to check for movement of the rib cage. And so basically what we're looking for is a decrease in the airflow at the nose and the mouth associated with continued efforts to breathe. This would mean that there's an obstruction in the upper airway. But we're also checking for the heart rhythm and the oxygen level at the same time. So the most thorough and precise test would be done in the sleep center. Now, some patients, in lieu of a test at a sleep center, will have a home test. The home test usually focuses on breathing problems, and so the home test would usually consist of a monitor at the nose and the mouth to measure airflow, a belt around the rib cage to measure excursions, and then a pulse oximeter to check the oxygen saturation and the pulse rate. So this is a test which, in the proper setting where there's a high suspicion for sleep apnea, may give adequate information. However, if another problem is suspected, another reason for sleepiness, or if the patient doesn't sleep well, or if the patient also has serious lung or heart disease, then the test really should be performed in a sleep center where a technologist is monitoring the patient. In this way, the diagnosis is more accurate and the patient is in a safer setting. So, for example, if their oxygen level should decrease or if there's a heart rhythm problem, some action can be taken in that situation.
Right away, yeah. Now, once you have a diagnosis of sleep apnea, what are some of the ways you go about treating it?
Okay, so we talked initially about weight loss, and so certainly in someone who has had an increased weight which has made the problem more severe, the weight loss needs to be addressed, and diet and exercise, and also, again, avoiding smoking and minimizing use of alcohol and drugs which could worsen the sleep apnea, such as opioids and sedatives. There are several types of treatments available for sleep apnea, and again, this is why it's important to get an accurate diagnosis as to the severity, because we will quantitate how often a patient stops breathing at night and how low the oxygen level goes. And so this will direct the care. If it's primarily snoring, perhaps some attention to obstruction in the nose would be sufficient. If it's a mild sleep apnea, sometimes a dental device fitted by a dentist to advance the lower jaw will solve the problem. But if the problem is severe or moderate, so if the episodes of not breathing occur 15 or 30 times an hour or more, the initial treatment is usually Cpap, which stands for continuous positive airway pressure. This is very effective treatment. It consists of a mask on the nose, or sometimes over the nose and the mouth, that delivers positive pressure to the back of the throat to hold the airway open. And in most instances, this is very effective treatment.
Does someone who has a CPAP, does that person have to basically use it for life thereafter, or is it more like a temporary type?
In most instances, it is a lifelong treatment.
Okay. Okay. All right. Moving on. Another condition that people might not be aware of: upper airway resistance syndrome.
Yes.
So what exactly is that, and how do you go about identifying it, treating it? Just give us a little general background.
Because that's interesting, because when people think of sleep apnea, they'll envision generally somebody that's quite overweight. Upper airway resistance syndrome is a little bit different from sleep apnea and occurs in a different population. Sleep apnea is also more common in men than in women, but upper airway resistance syndrome was described in the 80s and 90s as being more frequent in women who are not overweight. And so this is another form of sleep disordered breathing, but it's more of the subjective problem. And so this is in patients who snore and have very loud snoring, which may cause them to wake up for a few seconds on the electroencephalogram, but it's not sleep apnea. And so the oxygen level is fine throughout the night. So the problem is not decreased oxygen. The problem is that the person has what are called microarousals, waking up, at least as seen on the electroencephalogram, for 3 or more seconds at a time, and not generally something that would wake them up totally, but enough to interfere with the patient getting good, sustained, restorative sleep. And so these individuals will present with snoring, and again, they're more often women who are not overweight, who have the snoring and the arousals, and these individuals are sleeping in the daytime. They wake up, the patient doesn't feel refreshed, they feel sleepy in the daytime and in the afternoon, and this will interfere with their lifestyle. Perhaps if they're going out to a movie, they may fall asleep. It's embarrassing. And so this also does respond to CPAP, continuous positive airway pressure, but this is a very specific problem, not nearly as common as sleep apnea, but a very debilitating condition. So this entity can only be diagnosed in a sleep center because it does require monitoring of the electroencephalogram, or their brainwave activity, to detect it. And so it's really, if sleep disorder breathing is a general term and sleep apnea is the more common problem, upper airway resistance syndrome is less common. And it's still, even though it's been described, it still hasn't quite found its place in the whole categorization of sleep disorders. You had mentioned the CPAP before as far as treating it. Are there other options of treating it, or is that basically kind of the main? And the CPAP is the most effective treatment for upper airway resistance syndrome. And perhaps in a mild case, an oral appliance, but really the CPAP is usually effective. And in those individuals, since they're generally not as overweight, the tongue isn't as large, usually the pressure required is not quite as high as would be used to treat patients with sleep apnea.
Okay. What about something called periodic limb movement disorder?
Okay.
How about something like that? I mean, most people, like myself, don't know really anything about that, but if you describe it, maybe, you really help identify something.
So periodic limb movement disorder is an entity where the patient has repetitive movement in the muscles in the lower legs, and this is detected really with a lead on the front part of the legs, but also the rear part of the leg is involved. And so the patient will make repetitive, periodic flexions of the foot during the night. These can occur in one leg or the other, or both legs at the same time. And so if these are noted to be periodic, if there's a sequence of at least 4 within a period of a few minutes, this would qualify as periodic limb movement disorder. Now this in and of itself does not indicate a problem, but it is an issue if this wakes the patient up from sleep. Now the same type of activity can occur in the legs at bedtime, and so this is called restless leg syndrome. So periodic limb movement disorder and restless leg syndrome are really the same movement of the foot, It says that periodic limb movement disorder occurs while the patient is asleep. Restless leg syndrome occurs while they're awake. And so really restless leg syndrome is the problem that we ask about on the initial sleep visit. So in patients with restless leg syndrome, there will be a discomfort, an urge to move the legs, which is very hard to describe. Some say it feels like cola running through the veins, but it's enough to where the legs feel jumpy. The legs have to move, and so patients will notice this at bedtime. It will interfere with their falling asleep, and they'll either get up and move or sometimes physically try to hold their legs still or do something else to keep them from moving. So this restless leg syndrome is the counterpart that occurs during the patient is awake. And so this is really the disorder that is focused on.
How do you go, and this is, how do you go about treating that then? How do you really help people with something?
Okay, so there are, again, some lifestyle interventions. This may be associated with some medications, could be associated with some antidepressants, with excess caffeine, and also associated with certain diseases such as chronic lung disease and emphysema. Restless legs are also associated with low iron content, and so sometimes we'll check to see if the patient is anemic or particularly if they've got low iron, and so the treatment could involve changing medications and sometimes iron supplementation. But iron supplementation needs to be done very carefully and only under the direction of a professional, because it's possible to take too much iron. So if someone is started on iron, their iron level will be checked, and then after a few months, then the iron level will need to be rechecked. There are also particular medications used to treat the restless leg syndrome, and some are also used to treat Parkinson's disease, but there are a variety of medications, some which deal with the nerve sensations themselves, and others that deal with dopamine metabolism. It's felt to be dopamine in the brain which somehow causes this problem of excessive leg movements and discomfort, and so sometimes the medication used to treat Parkinson's disease can be given in a relatively small dosage at bedtime, and some patients will respond to that.
Okay. And how about one condition that we're probably everyone's familiar with in some way, just the insomnia type problem. Obviously, all people get this, periodically. So how do you tell the difference between, or what are the types, if there are types of insomnia? How do you separate, the periodic one that we all get once in a while versus a chronic type problem?
Okay, and so the classification of insomnia has evolved, and so the Sleep Association has a classification, but then the psychiatrists also have a classification, and so recently there's been an effort to have a similar classification. So in general, it's felt that insomnia lasting less than 3 months is felt to be transient or short-term. It could be intermittent or related to an upcoming event that the person is anxious about, but if it becomes habitual and if the insomnia occurs on an almost nightly basis for over 3 months, this is felt to be a chronic insomnia disorder, and so this would require a different approach.
Okay. Are there people who just function better? They have their night and days kind of swap. I know people who have trouble sleeping lifelong, and they seem to function better at night, and the reverse of most other people. Is that an insomnia condition, or is that just something that's out, something slightly different?
That's slightly different. So that would be more in the area of what are called circadian rhythm sleep disorders, and so these would be problems where the patient's tendency to stay awake or to sleep is different from the norm, which is to feel alert in the daytime and to feel sleepy at night. But I do know many people, often in the healthcare profession, who prefer to work nights, and it's just that they physiologically are able to do this, but they're still in a way working against the body's natural tendency, because at night when it's dark, the body temperature will decrease slightly, and so there's more of a propensity to sleep at night. But there are different conditions in younger individuals, say adolescents through early adulthood. There's a tendency for people to stay up late and to get up late. So these would be the night owls, and so but as people become older, and it's not clear if this is something that actually naturally occurs with age or if it has to do with institutions, but some people have more of a propensity to go to bed in the early evening and get up in the middle of the night, and so some of this could be related to habit or lifestyle. If the person has worked in an industry such as paper delivery for years, they may just get into that pattern. But so that's called advanced sleep phase, and so there can be different approaches to regulate this. However, if someone sleeps at times which are not the usual, but as long as it doesn't interfere with their ability to function or their education or their work, it's really not a problem in and of itself.
Okay. What about something like REM type behavior disorders?
Okay, that's a very specific, fascinating and scary condition. So this condition tends to occur more in middle-aged men.
Okay.
Men over 50 when it has its onset. And I'd like to talk about some of the different sleep stages that we will look at in the sleep clinic. And so there can be someone who's awake, someone who is in what are usually the earlier stages of sleep called non-REM sleep, where the breathing is generally pretty regular. And then there's another state called REM, or rapid eye movement sleep. And so this is a very fascinating state, and some would say that rapid eye movement sleep is distinct from non-rapid eye movement sleep as it is from wakefulness. There are changes in the autonomic nervous system. The body tends to be very quiescent, and the muscle tone is low with the exception of the eyes. Rapid eye movement sleep, which tends to occur later in the night, is the state in which most dreams tend to occur.
Right.
So the body should be totally still with the exception of the eyes, and there can be very vivid dreams or even nightmares, but still the body should be still. But if the body is moving during rapid eye movement sleep, if there's increased muscle tone, or particularly if patients enact their dreams, this would be consistent with rapid eye movement sleep disorder. And so if I see someone where this condition is suspected, again, I just listen. I'll want to hear what the patient has to say, what their bed partner has to say, and it's usually very clear, very disturbing. They say, yes, I used to play football, and I dreamt I was running with the ball, and then next thing you know, I'm out of bed elbowing the dresser, or my spouse is very concerned about this. And so this is a very specific problem. It's diagnosed in a sleep center. It requires monitoring of the brainwave activity and eye movements and muscle tone, and the treatment is very specific. So there are medical conditions and medications that can aggravate this problem, and there are some specific treatments, but really this is something that needs to be handled by a physician, either a general physician, a neurologist, or a sleep specialist, someone who knows what to look for, knows what to anticipate, and knows how to treat. And if the treatment can be quite gratifying, but this is a serious condition, and sometimes the response to treatment can be very gratifying, but it's a very unique problem.
Okay. And just generally speaking, what have you seen in terms of developments over the past, since you began your career, and what do you expect to see in the immediate future in terms of advancements in sleep medicine?
Yeah, hard to say. I mean, there's continued efforts to change the way that diagnoses are made. One entity I didn't talk about specifically is called narcolepsy. Narcolepsy is currently diagnosed by history of excessive sleepiness and episodes where patients suddenly lose their muscle tone when in a very strong emotional state. So, for example, if someone has narcolepsy and is laughing during a joke, they may exhibit something called cataplexy, where there's involuntary weakness. The current approach to this is to do a sleep test in the sleep center and then follow this with a test during the daytime to determine how quickly the patient falls asleep and to check the sleep stages. There have been some advancements in terms of the physiology of this and some data obtained by monitoring the patient's cerebrospinal fluid, but it's felt that there may be some advances in the ways that this is diagnosed in the not too distant future.
Okay.
In terms of sleep apnea diagnosis and treatment, hard to say. Cpap has been around for a long time, and it really is effective in most instances of sleep apnea. Other approaches have been tried. Again, in some of the milder cases, maybe a device can be used to advance the jaw. There is a relatively new, exciting, and very high-tech approach to sleep apnea, which involves placing an electrode in the tongue, which would stimulate the tongue muscle. And in some cases where a patient doesn't tolerate Cpap, this is something that's been used, but this is very recent information, and so that's something that may find a place in the treatment of sleep apnea. Otherwise, sleep medicine is an exciting field, and we treat the full range of sleep disorders, and the physicians involved in treating sleep apnea come from a variety of background. Often they'll come from pulmonary disease like I did, but sleep physicians may have a background in neurology or internal medicine or otolaryngology, which is ear, nose, and throat, or mental health. And so it's hard to say. There's a national conference coming up this June in Boston with the American Academy of Sleep Medicine and the Sleep Research Society, and so it's hard to say. But I would say more there will be advances in diagnosis and the treatment is ongoing. In terms of medication, these are evolving for problems such as insomnia and narcolepsy, and so I think there's a variety of fronts where we'll see some activity in the next 10 years.
Okay. All right. Well, I think we've had a really good show here today. We put out a lot of good information on sleep-related medicine and the conditions that are related to it, obviously. I want to thank Dr. Luke Pluto for taking time out of his very busy schedule for coming in today.
Thank you.
And I want to thank anyone who's watching. I hope you tune in next time for the next edition of Health and Wellness, and take care and have a really great day.